over the last few decades, there have been rising calls for universal health coverage, and it means it's a principle and a vision that all people have access to the full range of quality healthcare services they need when and where they need them without financial hardship. So that's kind of a mouthful there, but it's basically saying, very ambitiously, that everyone in X country, X community should have access to a good level of healthcare that they need, good quality, and they shouldn't go into bankruptcy. They shouldn't go into poverty. They shouldn't struggle to pay for it. It doesn't mean healthcare services are free, but it shouldn't break the bank. And unfortunately, in Asia and in many places around the world, that's exactly what healthcare is doing. It's making people contend with life-threatening illnesses, with severe morbidity, mortality, and at the same time, people have to think about their financial health. And these are some very deep and deeply personal questions that, as Cole had brought up as well, that we face as individuals, and governments are thinking about more broadly in terms of their commitments to societies and citizens.
The insurance industry really hasn't invested in the technology to transform the data they collect from what I would call in the kind of larger information technology data industry, data debt to a data asset. And what do I mean by that? So if I have 100,000 claims come into my insurance company every year, they come in basically in the form of a PDF. A PDF is locked data. It's data on a sheet of paper that's no more accessible to a machine than this is right here. When you have locked data, you're not going to get access to it. Right? Machines can't read it. If it's not tied into a knowledge architecture or some kind of a codex, there's no way to really extract that data. In the larger world of Salesforce or Amazon or Google, that's called data debt. It's not an asset because you can't get access to it. So while a lot of the insurers have giant warehouses, digital or physical, of claims, they have no access to that data. Right? So it really comes back to, if you're not looking at the bill, don't expect there to be a lot of price discipline. Now, the second piece of this that's really interesting in healthcare is that the industry, most of the claims are processed by outsourced third-party administrators. And the third-party administrators don't actually have a huge incentive to be creating digital assets, to be creating data assets, because they don't benefit from it. What they're paid for, what they're compensated for, what their incentives are, process efficiently. Process the claim efficiently. Well, if they leave behind 98% of the data in that bill in a PDF, that's okay. They still accomplish their primary objective.
So what was the, humorously put, the 20th century solution that insurance companies gamely tried to build? They built it on the back of an entire army of assessors. And the day they realized they can't incur the cost of those assessors, they then downloaded it to a TPA who would do that, hopefully with economies of scale, and deliver this. But the problem was that the moment you put human endeavor into doing something which is a low caliber work on a high data kind of a thing, you end up with suboptimal decisions. And the suboptimal decision, when we did this research, not only with this partner, but with a few other partners, mostly in the emerging markets of ASEAN, Middle East and Africa, that's where we now are growing in a very, very big way. We realized that only 10% of the claims seem to be getting straight through. The rest of them are going through some sort of a manual intervention. And in that 90% that is going through a manual intervention, almost 70-80% is actually getting approved eventually with no material savings or identification of issues. So the question that we need to ask ourselves is, why is there a 70-80% false positive rate in decision making if technology is something that... So you end up with a scenario where technology becomes a curse. Because if you just had a human executive, he would have been happy. Every claim he would look at it, he would identify the ones there's a problem and decisions would have been taken. But now you introduce the layer of technology that ostensibly claims to do something better, but it's actually creating more problems for the individual. So you end up with a mismatch of objectives. And this, to me, when I speak to all the business leaders in almost all the insurance companies across geographies, the message is none of their transformation agendas, particularly on claims, are working and delivering to the objectives.
Aspirations from digital health is to improve the access, as I said earlier, is to improve self-help and online care, and of course to see how we integrate that data into an EMR and into EHR. And of course, all of these ultimately should produce for us structured and unstructured experience data that can provide the insurance industry analysts and data scientists with the raw information needed to develop health and cost management solutions for policy development, rate making, strategic planning, improve patient health, and insurer financial outcomes. I'm a great advocate of a concept of health improvement. We hear terminologies like prevention, we hear terminologies like chronic disease management, etc., etc., etc. I think health improvement should be a very key focus, and to do that health improvement, of course, data and infrastructure. Who are the contributors of this data or the data generators? From a layman's perspective, we know mobile health apps, personalized medicines, telemedicine, electronic medical records, electronic health records, telehealth, and wearables are all general contributors to the data. But today we have much more. We have accelerometers from head to toe. We've covered in some way or the other, from an accelerometer to a thermometer. We've covered from different applications that take data from us, that take our experience, that take each part of us, each part of our movement, each part of our sensory system, and they are able to produce data in different perspectives. So head to toe we are covered. Head to toe we generate data on our own health, and it adds value to the data health generation.
Here another issue, again, if you move in the digitized environment, this is a case in Hong Kong only 2 years ago, medical identity theft. So here the scheme, quite smart. This is a syndicate organized. The law enforcement agency, the ICAC in Hong Kong, came up with this case. They were informed by insurance involved. So the scheme works the following. The syndicate actually bought insurance, medical insurance, with 4 providers. And you see it's quite substantial. The payout in this scheme, about $3.34 million US. So it's a big scheme, various insurance companies involved, a policyholder conspiring as a syndicate. And what they do is they put a cancer person forward to a medical provider. They ask for services, but this person is just a look-alike. So the policyholder, who is part of the syndicate, of the fraudster syndicate, is not the one claiming, but it's a look-alike. And the provider, for various reasons, couldn't do a test of the identity. So the cancerous person, who has no insurance policy, but claims he is the policyholder, he gets all the benefit. And in cancer treatment, it is expensive. And then later, the person who bought the policy but is not claiming for is getting some, usually fees or kickbacks. So identity was taken, was stolen, and the process was not robust enough to prevent that. The total sum here, $3.34 million US, quite substantial. That's one reason why now in Hong Kong they're going to build a medical database for the market.